Welcome everybody, good afternoon or good morning, wherever you might be. My name is Megan Rowling. I am a journalist with the Thomson Reuters Foundation and I am editor of Zilient.org, which is a news and information website focused on resilience for people working in the field of resilience. So today, as I said, we're going to be talking about innovating healthcare. And as part of that, we're going to be talking about how to achieve universal health coverage, which is part of the Sustainable Development Goals, to be precise, part of number 3, to ensure healthy lives and promote well-being for everybody at all ages. Now, at a forum in Tokyo last December, a declaration noted that by 2023, which is the midpoint towards the SDG deadline of 2030, the world needs to extend essential healthcare coverage to 1 billion additional people and half to 50 million the number of people being pushed into extreme poverty by their health expenses. And the World Health Organization said in its annual statistics report last year that globally 10 measures of essential health service coverage had improved since 2000. Those included coverage of treatment for HIV and bed nets to prevent malaria, as well as access to antenatal care and improved sanitation. But it's not all good news on the outcomes. For example, the WHO warned late last year that global progress against malaria had stalled, with cases rising in 2016, and most of those deaths are happening among babies and young children in sub-Saharan Africa. This week, however, on the upside, we saw about $3.8 billion pledged in London to drive research and innovation on malaria and to improve access to prevention and treatments. And there was also a major meeting on tackling malaria in Africa this week. So clearly there's a lot to be done to improve healthcare in poor and remote parts of the world. And today we're going to be talking about some of the innovations that could help reach the SDG target of achieving healthcare for all by 2030. First of all, we're going to talk with our panel. We have 4 experts today who are going to share their insights on these problems, and then we're going to let you put your questions to the panel so that we can have a discussion among ourselves. We're also broadcasting this webinar live on Facebook, so we're reaching the wider world as well, I hope. If you're tweeting about the discussion today, please try and use #GlobalHealth, or if it's specifically about malaria, I think #EndMalaria is a popular one. So I'll just introduce our panel first. We have Dr. Paul Richards, who is author of the book Ebola, How a People's Science Helped End an Epidemic. Paul's an anthropologist who has worked in Sierra Leone for over 40 years. He's an emeritus professor of technology and agrarian development at Wageningen University in the Netherlands, as well as adjunct professor at Njala University in central Sierra Leone, but he's currently coming to us from Wales, I believe. We then have Monica Kerrigan, who's Vice President for Innovations at Jhpiego, an international non-profit which is affiliated with Johns Hopkins University. Monica leads a team to identify novel solutions that can speed up progress in preventing needless deaths among vulnerable women, girls and their families, and she works to forge new partnerships with governments, businesses, donors and philanthropists. Before Jhpiego, she worked at the Bill and Melinda Gates Foundation, most recently as Deputy Director of Family Planning. We also have here in Barcelona, where I am as well, William Brent, who's the Chief Marketing Officer at Power for All. Power for All is a global campaign that advances renewable, decentralized electrification as the fastest, most cost-effective and sustainable approach to achieving universal energy access. It believes this can be achieved within 10 years for people without power in rural areas. And as part of his work, Will is often traveling to India and Africa, and he's worked with schemes that are setting up solar systems to power health clinics in areas that don't have reliable access to the grid. And then we are also lucky to have with us today Dr. Mouna Mayoufi, who is the Libya Health Coordinator with the International Rescue Committee, who has also worked in Syria and is going to talk to us about how we can deliver health services to people in conflict solutions. So we'll start by bringing Paul into the discussion. Paul, you've spent a lot of time studying the Ebola outbreak that happened in West Africa several years ago. And having been on the ground there and seeing what went right and what went wrong, I'm wondering if you could share with us some of the lessons that you drew from what happened in the sense of, in the end, the world was able to stop things getting worse, but I'm sure it wasn't all plain sailing.
Okay, sure. Yes, indeed, Ebola was a big problem because it was a new disease in Upper West Africa. There was no experience with it at all. So there was a lot of anxiety, especially by international responders, how quickly they could prepare local populations to do what was necessary in terms of protecting themselves, in terms of quarantine. And I think the international community wasn't quick enough to engage local agency in that activity. It was all done, as someone once said, from the back of a truck with a loud hailer. A lot of people were out there telling people what to do. There was very little engagement with local communities asking their advice on how to achieve the goals of Ebola protection. But it didn't take long before evidence built up that indeed there was a lot of capacity developing within the local community from a baseline of nothing, because they'd never experienced a disease like this before. But one of the things that built up local knowledge was that when you have an attack, because it's based on bodily contagion, you can see how it's spreading. You can see that the people who are most diligent in caring for the sick are the ones that next get the disease. So it didn't take more than a few weeks in some communities where there was a very heavy outbreak. Maybe every family in the village had an Ebola case, and people could see that it was affecting the daughters that cared for their mothers. It was the children that had come and looked after the father, that kind of thing. And so they started to devise protection. They improvised plastic bags, goggles covering their face, whatever. And some really remarkable stories came to light about people who'd survived Ebola and helped their families survive because they were taking sensible protection. And communities then became very heavily engaged in imposing quarantine. So a lot of communities said, well, look, we're spreading this around. It's because we're moving around and people are not being very disciplined about where they go and who they've been with and so on and so forth. So you had a lot of community action, often led by local leaders, but in which there was a great deal of... I
think we might have lost Paul there. He seems to have frozen slightly. Hopefully he can join us again shortly. We'll wait and see if Paul reappears. In the meantime, I think we'll have to go to Monica next from Jhpiego. Monica, Jhpiego does a lot of work with women and young people in communities around the world in many different countries. Could you tell us a little bit about your approaches and how they draw on those community efforts that Paul was mentioning?
Would love to, and one, thank you so much. I am so honored to be a part of this distinguished panel. Jhpiego works in 40 countries around the globe, mostly in sub-Saharan Africa and Asia, and we strengthen the performance of health workers and communities to save lives of women, young people, and their families. And our topic today is really about innovation. And when we think about innovations produce positive health outcomes for more people, faster, better, more affordably and sustainably. And we work on areas such as HIV/AIDS, TB, malaria, family planning, maternal and newborn health, and cervical cancer. And one of the things that we do is we work with a multidisciplinary team, and we support our country programs, both from the program lens and from the technical lens. And we start off by deeply understanding the problems that our communities and mothers and youth have in accessing services. And I think one of the lenses that we certainly use, and I think many people are using, is to fall in love with problems and work with the community, work with our clients, work with our beneficiaries to use a human-centered design approach to problem solve and to design programs with the community on behalf of the community. And so I'd like to give you two examples of work that we recently did. One was in Ghana, where we worked with pregnant adolescents and postpartum adolescents. And one of the things, obviously, is that many of the times we have focused our approaches in facilities. And the more that we reach out to community members, the more that we use a human-centered design approach and to be very honest, lead with empathy. Walking in the shoes of our clients, we've realized that how much more we could do with engaging them in the design process. And so we facilitate the process, but they design their programs. Local problems, local solutions. And I want to give a big shout out to the young people and the communities who engaged with us in Ghana, because they really helped us strengthen our program there. And now we have a very much more community-based intervention and using their ideas and building on their strengths. We also recently did a workshop on postpartum family planning in Bangladesh. You know, there's more than 3 million births a year in Bangladesh. Many women aren't offered birth spacing counseling. Many women aren't offered immediate postpartum family planning after their delivery. And those women and their providers and communities came together along with the government to help us think through, well, what are the barriers to care and how can we do a better job providing more people-centered design care. And so we worked with them, and it was interesting. Many of the issues that were brought up had to do with the cultural issues of getting their families, mother-in-laws, their husbands on board to accept family planning. More than 90% of women want to they don't want to have a birth in the next 2 years after they've just delivered a child, and they're looking for new opportunities, but they didn't find the support within their family situation. And so thanks to this human-centered design approach and thanks to the work that we did to bring communities together and to learn from them, I think we are designing better programs that are more impactful and more efficient by putting people at the center of our programs. And that really empathy drives innovation. And maybe on that innovation note, and you brought up certainly universal healthcare coverage and the importance of what's happening around the world today in malaria. But I just wanted to share our excitement and enthusiasm. In so many respects, we embrace the bold vision of living in a world free of malaria. And right now in Dakar at the Pan-African Conference and recently at the London Summit, you saw the world come together. Partnerships between government, the private sector, NGOs like ourselves. And it's exciting to see our malaria director, Dr. Gladys Tete, is out in Dakar. And she gave me some information regarding that conference. And it's palpable to see and to hear people come together and say, listen, we have made progress in reducing malaria deaths, but we are stalling. And now we need to up our game. We need to dial it up, and especially in our communities. And so one of the things that certainly Gladys mentioned was the excitement of the community coming together and to hear commitments by governments, for example, in Senegal, where they made a $35 million commitment to end malaria there by engaging communities. And they have a Zero Malaria Starts With Me campaign. And I think it goes to the fact that each one of us play a role in ensuring we are saving lives. And I think there's a great opportunity in the malaria community now, both at the global level and at the country level, to drive that change. One of the
Thanks, Monica. Thank you very much. I just wanted to try and bring Paul back in at this point, because just picking up on some of the points that you've been making about bringing communities into the design of healthcare solutions that will work for them. I was wondering, Paul, sorry that we lost you earlier. You were in the process of describing some of the things that communities came up with to deal with Ebola that indeed worked for them. And then just to sort of broaden that out to malaria, do you feel as if those solutions have been used in tackling other diseases at this point, or has the world not really listened to the experiences that came out of the Ebola crisis?
I think the world has listened, and indeed we got a grant from the Dutch government to go back and to work with some of the community groups that were so innovative in dealing with the Ebola threat, and to ask them the question, what next? And when we asked them what next, they all said malaria. They said that's far more important than Ebola. Ebola, we hope it will never come back. We know now how to deal with it. But the malaria thing is where we want to be going. We engaged at the community level. We organized ourselves. How do we continue that engagement? So one of the things that we then brought to them to see whether it would work was something that's in Europe and the Netherlands is called the Science Shop Initiative, where you say, okay, communities have problems, they know their problems, but they don't know everything about the problems. So they want to call in or call down, draw down scientific knowledge. And this seemed to fit very well when we talked to people about it, because they said, well, yes, of course, we know in general that this disease is malaria. We can detect it. Mothers sense it even in their children's bodies when they're carrying them on their backs. But we don't entirely know how it's spread. And we know it's about mosquitoes, but we know there's different kinds of mosquitoes. And come and work with us so that we can see some of these things. So we had an absolutely amazing 3-day workshop working with village women, with young people, elders from the community. Everybody was there. And they became totally enthused with collecting mosquitoes, learning to identify the ones that were dangerous for them, which diseases the different species carried, which were the ones that are just a nuisance because they bite you, but you don't have to worry about getting malaria or yellow fever from them. And they said that was good. We're now really understanding the problem, and we went out into the bush to find out places where mosquitoes were breeding, to identify the larvae, different types of larvae. And then they said, okay, so now we can begin to think about a control program, because we have the necessary knowledge. And I think that's where a lot of emphasis should be put in. Malaria is not really, shall we say, a medical disease. It's a disease of public health. It's a disease of sanitation. And getting the community engaged in dealing with sanitary issues, I think, is where we should be. So that's how to carry on, I think, from what we learned with Ebola, to turn it now into a major grassroots campaign for dealing with malaria risk and reducing malaria risk.
And what's very interesting about what you've just described is that it seems to me it's a combination of both local knowledge and then scientific knowledge and social science approach as well. So, I mean, what are the optimum conditions for doing that? It seems as if it might have to be very context specific, but are there things that can be taken from one situation and used in another situation, or indeed for another disease?
I mean, I think it is context specific, because malaria risks, because of all the vectors involved and the complexity to do with where they breed and the seasonality factors and so on, no two malaria environments are the same. So there's a premium on good local knowledge, and that knowledge has to be built up by local participants. But trying to mobilize, that's something I think where we know that people can do it, but they need resources, they need energizing. And in a sense, it's almost the idea of the Science Shop Initiative is that you give people purchasing power. You say, okay, we, a group of scientists, typically master's students, PhD students with a supervisor or two involved. Sometimes we get publishable material out of this, but basically they're waiting for an invitation for the community to say, come and show us how to do things, or come and discover things that we don't yet know, so that we can then take the solution into our own hands. So building that constituency for basic science is really quite a challenge. But it was quite amazing. These people, they didn't read and write, many of them, but they turned it into song and dance. The women, every time there was an important point to learn about malaria mosquitoes, the leader of the women's group got up and she turned it into a little song and a dance, and they learned the lesson. This is the one that spreads Zika, this is the one that spreads malaria, and so on. And they did it all themselves. So community empowerment starts with giving people the capacity to draw down and build knowledge. And we don't really have good infrastructure in place for that. Even universities within the region, they're much closer to the problem, but still we tend to go out and say, oh, we've got the solution, here it is, do this, do that. And so we end up with the Ebola people with a megaphone on the back of a truck telling people what to do. We need to change that. We have to be much more collegial with communities in terms of building new knowledge to deal with basic diseases like malaria.
Absolutely. And Monica, I just wanted to bring you back in at this point, because obviously you're trying to adopt that collegial approach as well, possibly from a slightly different perspective. But I was just wondering about the role of business here. How do you bring business into the equation as well, the big pharmaceuticals or the big companies that work on healthcare delivery? How does that work best so far in your experience?
Great question, and I think the Dakar conference and the London summit this week actually demonstrate the power of these partnerships, both at the global level and then at the local level, where private sector is very engaged in working with governments and civil societies like ourselves to really bring this home, and I think that's where that government commitment to bringing together partnerships, having a costed implementation plan, bringing together these partnerships. Each one of us has a special role to play, and maybe there are many neglected areas in public health. Certainly one of them is also on the issue of safe surgery and bringing together partners. The GE Foundation is funding, I think, one of a very exciting initiative called Safe Surgery 2020. Again, bringing together partnerships of government, private sector, and researchers to really help us really drive better access to surgical care in this neglected areas. I know the malaria community and the family planning community are doing the same. I think one of the certainly areas is that the country's commitment to bring those partners together and to utilize our strengths and build a collaborative advantage, or the partnerships can drive that. And again, I do think malaria in pregnancy is also a huge killer. And when we see those partnerships come together where insecticide treated bed nets are provided, that supplies and drugs are being provided, the private sector is helping us work through logistics and supply chain, so we are no product, no program, really becomes the reality. But I would love to, again, reinforce what, Paul and we were both saying, is it really begins at the community level, that the community cannot be left out. They must be a part of the planning process. They must have a voice in the design and also in the accountability framework. And I think innovations does continue to play an important role. We have programs that are using SMS systems that allow us to more quickly diagnose and treat mothers and their children. And I think in the future, we'll see a lot more opportunities for innovation, both on the vaccine side, on better drugs, better pesticides. Malaria control is an area where so many different solution levers have to be brought together, and not one group or one person can do this alone. It's really in a partnership that we need to accelerate the changes needed to be made to be in a world free of malaria. So thank you.
Absolutely, Monica. And another area of healthcare where innovation is required and partnerships are very important is in the provision of energy to healthcare facilities, because if healthcare facilities lack access to power, reliable energy sources, then they cannot deliver healthcare to their optimum capacity. And I noticed when looking through the Power for All materials, Will, that you note that 1 billion people around the world are served by health clinics and hospitals that lack electricity, which is a fairly astounding statistic. And so I was just wondering if you could fill us in a little bit on some of the exciting things that are happening in this space, especially in the provision of solar power to clinics in remote areas. Thanks.
Sure. Yeah. Thanks, Megan, for inviting me to be here. Yeah. So I think, first of all, I think, there's the delivery of healthcare aspect to energy access, but there's also just the impact that innovation in distributed renewable energies over the past decade have had on health. Not necessarily the delivery of healthcare, but on health itself. So, you know, there are now tens of millions of people in sub-Saharan Africa, in South Asia, and elsewhere who are now using solar lights, solar lanterns, solar home systems that have all been enabled through innovation in distributed renewable energy, who are no longer using kerosene. So kerosene is being displaced. Therefore, the air that they're breathing inside their homes is much healthier. Same thing with diesel. A lot of diesel generation is used, very polluting, very dirty. That is also being displaced by distributed renewable energy. So, and you have the emergence of solar-powered pumping, both for clean drinking water as well as for irrigation of agriculture. So you're increasing outputs of your farming, which obviously provides more food and better nutrition that impacts health outcomes, as well as having pumps powered by these distributed systems that are providing clean drinking water to communities that are then therefore free of waterborne disease. So I think there's a huge impact that distributed renewables has had on health and continues to have on health. But now we're also starting to see, and I think where this is the conversation is really focused around the delivery of healthcare and where distributed renewable energy can make a difference there. And we're starting to see some really interesting things that are emerging. I'd probably split them up into two aspects. You mentioned, you know, there's a billion people in the world who are served by clinics who don't have electricity. There's also a billion people in the world who don't have access to electricity. I'm guessing, although I don't know any data to prove that the overlap between those 1 billions are basically the same population. We serve primarily a rural population who lack electrification. About 85% of them live in remote areas. And we're seeing a lot of innovation happening both in the hardware side of things, as well as the software and delivery of services side of distributed renewables. So we almost see the provision of electricity to these communities as the tip of a spear for enabling many types of services, including healthcare. And so, you know, you have companies now who are, you know, using pay-as-you-go mobile money models to sell electricity and solar home systems to these homes. But on the back of that, using that as an entry point to add additional services, whether that be a fan or cooling devices or induction solar cook stoves, and then potentially other services around health. So part of that service model is also about selling smartphones to these homeowners in rural areas. And you know, you can imagine that once people have smartphones and connectivity through the provision of electricity, that the potential for introducing telemedicine it becomes much more interesting. And so how do you come up with new business models to take advantage of the smartphone technology, the electricity to power that, and telemedicine and the delivery of healthcare?
Increasing, Will, in terms of bringing all these things together. I mean, there seem to be there's so much potential for improving health outcomes using decentralized renewables. And I think things are starting to move, right, aren't they? What sort of stage are we at, and what are the main opportunities? Who's getting interested in this provision these days?
Okay, that's a big question. You know, it's a complex one to answer. I think, you know, if you look at the development community overall, they tend to be quite siloed. And I think that's why I'm really excited to be here on this panel, because I think it's great to see people coming together to actually talk about how can we work together to better deliver services like health. You know, and our sort of thesis is that, you know, if you have to deliver electricity access by 2030, and we're successful in doing that, well, then how are you going to deliver universal health care by 2030, right? Because you can't do that without provision of electricity first. So we're sort of moving up the timeline to 2025 and saying, okay, let's do this first. But in order to do that, I think what you're asking is, how do we make that happen faster? And I think there has to be a much greater level of collaboration across the various development goals, if you will, healthcare and energy in particular here. I think there's, you know, I can just thinking about malaria. I mean, I'm just talking out loud here, but hearing what Paul has to say and what Monica said, you know, how do you bring the water community together with the health community, together with the energy provision community, and figure out a way to bundle those things for rural communities so that we're solving all three things at the same time. We're preventing malaria, we're providing the delivery of clean drinking water, and we're delivering better health outcomes. You know, so I think that, I just think there has to be a whole step change in terms of collaboration and willingness to cross silos.
Absolutely. It seems quite obvious when you say it in a webinar, perhaps, but I wanted to bring in Mouna, maybe at this point from IRC for a bit of a reality check, because, you know, we're talking about, in an ideal world, what could be done to solve some of the health problems facing communities. And, you know, every community is in a different position, has a different level of prosperity, has a different level of challenges facing them. And Mouna, you work with in some very difficult environments in the Middle East, Libya specifically at the moment. And I just wondered if you could tell us a little bit about how you go about getting healthcare to some places which are affected by conflict, where it might seem an almost impossible task.
Yeah, hello everybody. Thank you for the opportunity to provide field insight on the challenges of delivering quality healthcare in affected crisis environment. Yeah, obviously it's adding another layer of complexity to the issues we are discussing today, because the common characteristic of the crisis are basically the breakdown of the institution, weak governance, and public administration, ongoing conflict, and the longevity of the crisis. I will focus basically on the operational challenges in Libya, just to explain what are the main challenges. For instance, in Libya, the public health system is highly centralized system. Even like prior to the crisis, the health system placed very little emphasis on community-based preventive healthcare and on primary healthcare. There is now, with the crisis, a high risk of spread of communicable diseases with surveillance system and limited preventive measures, that we could definitely benefit from the technology in this areas. Primary healthcare centers have no capacity in terms of triage, stabilizations, and referral of emergency cases, and there is a very limited capacity to manage the heavy burden of the non-communicable disease that is like the biggest burden in the Middle East and North Africa region. Besides the unavailability of mental health services. Medical supplies is also a big issue because there is a lack of drugs and medical supplies and equipment. For instance, stock of family planning medicines in public primary healthcare center is at 2%, which indicate that no family planning services are actually available in the public sector. IRC, for instance, import all the drugs and medical supplies that we are using in service delivery, and it takes us a long time to bring this drugs to our clinics in Libya. In terms of human resources, there is a huge lack of qualified human resources in some areas, because even prior to the crisis, the system was highly dependent on foreign workforce. That all of them have left the country, and now there are also difficulties to pay staff salaries because of the liquidity in the country. All of this is also linked with administrative and logistical difficulties, with the high inflation and price volatility, and poor diversity of goods and supplies. And within all of this, there are also the security challenges and difficulty to access due to irregular clashes, kidnappings, car bombings, etc. etc., which disturb the activity of our regular activity.
But nonetheless, you're managing to operate in, especially in the west of Libya, right? I read something recently about how you were doing that, literally by kind of driving around with staff and supplies in a van, right, to different local facilities.
Yeah, so the IRC is responding to this crisis with service delivery, but we are also providing health system strengthening. So the service delivery part is actually this mobile teams that are roving around the pre-existing health facilities and providing medical consultation to patients in need, Libyan and migrants, because there is also the migrants community that is a big burden of the health system in Libya. And besides this, we are also working with the local authorities, the Ministry of Health, to strengthen the capacity. Because obviously there is a need for a joint planning between the health system strengthening and humanitarian intervention. The collective outcomes should be identified from the onset of the crisis, and systems should be put in place to track short, medium, and long-term health outcomes. So yeah, for the IRC, it's clear that the humanitarian intervention should focus on integration and transition to local authorities as early as possible. But in the same time, development work stream should target fragile and conflict-affected areas in more operational manner. And this is what we are really trying to bring in on the discussion in Libya and in Syria as well, with the humanitarian development nexus discussion.
So basically, you very much have to try and work with the authorities in order to be able to build something that's more sustainable, I guess. Once the conflict situation alleviates or it becomes possible to transition to a more normal provision of services. I just wanted to, before we start broadening out the discussion, I just wanted to say to everybody who's watching or listening that they are welcome to submit questions for the panelists, which you can either do in the Zoom webinar chat, on the side of your screen, I think, or via the comments section on Facebook. So please do feel free to pop some questions in and I can put those to the panelists. But while you're thinking about the questions that you might like to ask, I just wanted to put a broad question to the panelists, one that came in via the pre-submitted questions that we had, and also touches on what you were just saying, Mouna, this issue of working with governments and needing to work with governments. Perhaps we could start with Monica, and if you wouldn't mind keeping your answers fairly brief this time around, panel, that would be great. I mean, what's your approach to working with governments? Do you do that in every single situation, every country that you're in? And how do you go about it?
I would say yes, we are a trusted partner of government. We work very closely with the government, but they're not our only partner. You know, certainly governments set plans and priorities, and with that government commitment, we try to drive change, but we also work with the private sector and I would say professional associations, youth groups. When we think about bending the curve, and accelerating the impact and progress, we feel that governments are an important entities. They own and sustain the issues and the impact, but we can't do it alone. And so I would like to hear more from other people. But yeah, I think one of the ways that we drive impact is through our government programs, and many of our actually through our government programs, they sustain it. We prove a concept and we scale it up, and they maintain and sustain it moving forward.
And Paul, what's your experience been in West Africa? Has it always been an easy task working with governments? Do you feel that they really stepped up during the Ebola crisis, for example? And how do you feel about West African governments' engagement on malaria?
Obviously, you do have to work with governments. Communities work with governments because they've got government functionaries based within them. So you've got a hierarchy of chiefs and administrators and so forth, and they're the front line for dealing with epidemic diseases like Ebola. And I think government itself in the 3 countries that were affected by Ebola, I think there's been quite a great deal of honesty in facing up to the fact that the early responses were not very well carried out. Everyone was in a muddle. Communities were in a muddle. International responders were in a muddle. Governments were in a muddle. It's a question of who got up first, who organised themselves. And I think governments have learned a lot from the Ebola experience. And you now see there's a new commitment to try and drive health services further into the inaccessible parts of the country. There's some interesting new developments in Liberia and in Sierra Leone in terms of rural accessibility. We found that in the Ebola epidemic that commercial motorcycle riders were able to get to the parts that others couldn't get to. And there's now increasing interest in trying to do track development and improve accessibility for at least the 2-wheel vehicles, if not for 4-wheel vehicles. So those are all good things that are happening. Lessons are being learned. But I think there still is a certain amount of conflict often between communities that have looked after themselves. Their own health care has been their priority, and no one else is going to come and help them. And then there's the arrival of international agencies and government health services. And sometimes there's tension. There's tension because different professional organizations have different ways of looking at the problem. And all the things that have been said about being open to communities and collegial with communities are really important if you're going to try and bring about an effective marriage of all the different responders as are necessary.
Thanks, Paul. And Will, how does that work when it comes to decentralized renewable energy? I mean, obviously you have to have the right policy frameworks in place, I guess, for these kind of systems to gain traction. And we've definitely seen that happening in East Africa and India. And, you know, perhaps you could share a little bit of your experiences in terms of getting the right kind of support for this this particular form of energy provision.
Well, I mean, I'll keep it to the conversation around healthcare, but it's still related to energy. And India is probably, you mentioned India, they're probably a good example to use. I mean, where the government has been very good about trying to combine these two things, right? So they're looking at a country where there's 38 million households who are served by clinics with no electricity. The government's very proactively trying to address that. You know, these are clinics, primary healthcare clinics out in rural areas. They get spotty and unreliable grid electricity at best. Distributed solutions are much more reliable, higher quality. They don't have voltage fluctuations that can impact medical equipment. So the Indian government sees the value in solar, and they did a pilot program in Chhattisgarh state that a research organization in India, CEW, recently did a study of where they deployed rooftop solar on 500 clinics, it was more or less. And the outcomes were phenomenal in terms of the improvement of daily operations, in the percentage increase in terms of inpatient services and deliveries and laboratory services. All across the board, there were positive metrics of impact. And now, you know, the government's seeing this, and as part of their effort to both deliver universal health care and universal electricity access, they're saying, okay, well, this worked in Chhattisgarh, why don't we roll it out nationwide? So I think, you know, government is complicated, as everybody I think on this panel would agree, but, you know, without a public-private engagement on these things, it's just not going to happen.
Right, absolutely. And then in terms of the funding that's required to get us to universal health coverage and universal access to energy, where is the bulk of that likely to be coming from? I mean, is it a question that money's just not going to the right places, or that it's being invested in the wrong things? Or is there a need for a much greater level of investment in healthcare, and also by default in the provision of energy to healthcare? And where is that going to come from? I'm not quite sure who'd like to come in on that first. Maybe Monica, you'd like to?
Well, there is certainly a global gap in terms of funding, and I think everyone is looking for ways, one, to optimize the funding that we have and ensure further transparency and accountability and governance there. In saying that, if we could optimize those efficiencies, I think there is also an agreement that there is insufficient funding to drive down maternal, newborn, and child deaths, including HIV/AIDS and malaria and TB. So I think on both fronts, we're looking for ways to better target our funding and ensure those interventions are high impact, and look for, I think, ways to do some, I would say, have some new business models. Some of the work that the Gates Foundation and other people are doing, looking at volume guarantees, working with the private sector and drug companies to look for more effective and efficient pharmaceuticals and medicines. So I think there's a lot of opportunity and space and innovation to do new things there. But in saying that, I think it's one of our biggest challenges as we move forward.
And Mouna, I wanted to ask you about this. You know, one of the problems with in the humanitarian sector is that needs are massive and resources are finite, and donors prefer to put money into some things or some particular emergencies rather than others, depending on political expediency and other factors. How do you find the situation for healthcare in Libya and Syria? Is finding the aid money to cover those emergency service provision, is that a problem, or is that an area that donors are quite keen to put money into? And also when it comes to building more sustainable healthcare systems, how is the funding situation there?
Yeah, obviously there is a tiredness in the funding of such a long crisis. Like we saw it in Syria, each year the funding humanitarian plan was decreasing progressively, and even all the requirements that we've been putting, they were never met. So last year the HRP was funded up to 36%. Same in Libya, the HRP, the humanitarian response plan is not funded. Is funded up to 40% again. So there is a lack of funding for the humanitarian crisis, especially as well when the government are also part of conflict. This also complicates a bit the fundings and the development of health system as well. For instance, now in what we are trying to work on with donors in is to try to find new funding strategies, ensure that the funds that are dedicated for development, there is a kind of silo approach among development donors. They are targeting specific target population. They are targeting specific areas, and while we need to have a comprehensive approach for the strengthening of the health system, we cannot just target migrants, because it doesn't make sense to provide health services to migrants while the local population is not accessing quality service.
So there are quite a few different challenges there, which, you know, is I'm sure making your life difficult on a monthly, if not daily basis. But I'm just seeing here a question coming in for Will from someone called John. I'm not quite sure where John is from, but John's saying, can we scale up energy access without donor funding, or perhaps with public-private lending to finance the solutions that can be repaid over time? Health centres and individuals are paying for energy today, including generators, kerosene and batteries. And, you know, he's bringing up the example of Steamer.co, which is investing in microgrids in Kenya. So do we even need government funding for what you've been talking about, Will?
Yeah, well, these are public services that we're talking about, right? I mean, delivery of healthcare in many countries I'm American, so unfortunately I have to pay for private healthcare, but in many countries, and I have to deal with our government, apologies. So I think, you know, in many countries, this is a public service, right? So clearly public funding is going to be needed, especially for rural clinics. that are serving, largely poor communities who don't necessarily have the money to pay for these types of services to begin with. So clearly there's a need for donor support. There's clearly a need for public support. Again, it's a mix. And I think there are some amazing things happening in the private sector. Many of the companies that we work with are doing mini grid or solar home system, pay-as-you-go solar companies. They're going to do some amazing things in healthcare, but it has to be, multi-pronged.
Yeah, and absolutely, each situation is different. And I'm wondering if Paul sees, like Mouna was mentioning, this kind of interest ebbing and flowing from the donor side. 1 year, one crisis is in the spotlight and the money's going there, and then another year somewhere else, and there's a finite amount of money. And I'm wondering, Paul, if you've seen, for example, post Ebola, there was a lot of interest in those type of healthcare situations, and now people have been raising the alarm about malaria. Is malaria, the current disease that's most likely to soak up donor funding? What are you seeing on the ground?
Well, you characterize the situation well, because the fads and fancies in funding are really part of the problem. And it's to my mind, having reflected upon it over many years, it's something to do with lack of empowerment of communities to be responsible for their own development. You can't really get international agencies that will put financial resources into the hands of communities. And if it's an issue of trust, no one seems to be doing the basic thing, which is teaching community members, community representatives, how they can handle the resources better. I think we could make use of vouchers quite a lot more than we do for certain basic healthcare provision things. But place the purchasing power, place the initiative, place the planning back in the communities, and stop this business of changing fashion. For 3 years it's this, for 2 years it's that. In the middle of the Ebola outbreak, I was asked a question by a villager, a wry question, irony written all over their face. They said, now everything is Ebola, where did all the other diseases go to? That was a wonderful question. And of course, the point was, the answer was there. The disease didn't go anywhere. It's just that you've stopped funding malaria and anything else. You're putting all the resources into Ebola. And why? And that inconsistency and that lack of focus, I think, is really something which is damaging communities and has to be changed.
It just made me think, Paul, actually, because I work quite a lot on climate change, and there have been some interesting experiments going on, in fact, backed by DFID, of one particular project comes to mind called Decentralizing Climate Finance, where the whole project is about building up a system for communities to plan their own projects, and then to, within the country, develop a financing system with checks and balances that will allow much larger amounts later to be channeled through that system. So I'm wondering if there's an argument for decentralizing health finance program, or perhaps those types of experiments already exist. I don't know if anybody is aware of those kinds of capacity building efforts, if you like. If so, please do fill us in.
Well, I think you've said it wonderfully well. But decentralization is very hard to do because there are people at the center who hold the money and they don't want to see it going into other people's hands. So at the end of the day, it's a question of political will. If the international community wants to do those sorts of things, it can do so. If national governments want to decentralize, they can do so. But the first thing is to have that willingness to allow local empowerment to flourish.
Monica, you had a point to make?
Yeah, I actually think decentralization is a big part of the game now, and you see it across sub-Saharan Africa and Asia. I lived in Indonesia, and they are highly decentralized down to the district level, and health is actually the power of health and the rights to finance it is really at that community level. And I would say that there are now community scorecards that youth are using, that associations are using to keep their governments accountable for what it is that they've told their citizens that they're going to be doing. And I know Kenya has recently decentralized to their 40 counties. And so you see this growing efficiency in that area. So yeah, I think we'll be seeing much more of this in the future.
Yeah, which could lead to some interesting experimentation. Sarah Page in the chat made the point that DFID is more adapted to flexible funding models, while USAID is constrained by Congress and fiscal requirements, you know, which kind of underscores how donors do have a lot of different ways of operating, and trying to fit within those can be very difficult, even if you one side thinks they've got the next best thing and way of doing things, and yet other donors might not agree with that. It doesn't make life easy for you. But anyhow, you have to operate within those constraints. I'm aware that we've only got a few minutes left, so I just wanted to bring things to a close really by just asking the panelists to give us a few final thoughts. I suppose just as a question to put to you, if you were to single out one important policy, one important change, one important development that could make the biggest difference in terms of speeding up universal access to healthcare in your context, what would it be? I don't know who would like to chip in first there. Will, maybe I'll bring you in at this point.
Yeah. So I think you know, I would just encourage everybody who's involved in healthcare and delivery of healthcare to the same community that we are to make your voices part of our campaign, because we're just the energy sector, and you know, energy is invisible. It's very hard to see the benefits of electricity itself, but you can see the benefits of better healthcare. And in order to get the electricity delivery systems in place to deliver healthcare to these billion people, or more than a billion people, we need your support in making the case to institutions that currently spent a pittance of their annual energy investment on distributed solutions to increase that significantly. And so that would be my one request.
Okay, and Mouna, how about you? What would make the biggest difference to your work in the Middle East?
Yeah, I think what we should focus on is the early recovery approach. I would highlight the need to expand access and coverage and quality of an essential package of health that should be rolled out even in the places with a big with protected crisis, a big emergency, because it's needed. It's the basic of provision of quality, and that builds also the health system later on when the crisis is over.
Okay, and Paul, in West Africa, in your battle against malaria, what would be the one thing that would really help you push things forward?
I think we've said it already, decentralization. If you go with what communities are interested in, then they would want to go back to a much older way of dealing with malaria, not placing all the emphasis on medical solutions, not looking for vaccine solutions as the priority, but dealing with sanitation. There are, in fact, local officials in every village in Sierra Leone called sanitary officers. They've probably not been paid in the last 10 years. That's how serious we are about dealing with malaria. When we see some seriousness coming into sanitation, the ministry in Sierra Leone is called the Ministry of Health and Sanitation, but the emphasis is on health, and there's very little organized attention to sanitation. So shift that and make it coincide with where people's priorities are, because they live in the environment. They want to clean it up. They want help to clean it up. And that anything that conduces to genuine decentralization is going to help with malaria and many other healthcare delivery issues as well.
Indeed. Thanks, Paul. And Monica, just from the bigger picture perspective, bringing all those things together, from Jhpiego's viewpoint, what would be very useful to you in terms of scaling up the impact of what you do?
Yeah, I think it is on innovation to save lives. I think we have to create more urgency and remember that we have to continue to look at ways to be impactful and results driven, and we can't do it alone. And I think it's through these partnerships with government, with civil society, with the private sector, all coming together and really amplifying our voices and ensuring that the community and those users are people-centered approaches are going to remain key to that saving life approach.
Well, thank you very much indeed, everybody, for a fascinating discussion today. I think we've managed to sew together a patchwork of different interests, different expertises, and what I've sort of brought away from it is this real need to focus on what communities want, what communities know, and what communities need, and then trying to work across all different sectors in order to meet those needs in a much more joined up way, and making sure that the money gets to where it is required. And only then are we going to start to have a more holistic approach to bringing health coverage to everybody by 2030. So I guess it's a question of keeping on working together and in order to make that happen. And I'd just like to thank everybody also for listening in and watching. And in order to keep the conversation going, we will write a piece which will be on www.zilient.org with the key takeaways from this discussion. If you would like to revisit it at all, there will be a video that you will be able to watch on our website and also on Facebook. But once again, thank you so much to our panelists for their great insights today. And we'd like to welcome everybody back for the next Zilient webinar, which will happen sometime in May. Stay tuned. Thanks very much indeed, and goodbye.